The last speaker is Professor Banu Arun, Professor of Breast Medical Oncology, Coordinator of Clinical Cancer and Genetics, University of Texas, MD Anderson. The title is Approach to Personalized Breast Cancer Management.
Thank you very much, dear chairpersons, dear colleagues. Again, thank you for the organizers for inviting me to give this talk. I will also try to keep it short. I think the last talk of the session will be Approach to Personalized Breast Cancer Management. I know our previous speakers did a great job in summarizing approach for advanced cancer. I'll try to focus more in the treatment and personalized management of early breast cancer. I think we all know, and I think have seen multiple times now in this meeting as well for the last 2 days, that breast cancer is a heterogeneous disease with multiple genotypic, phenotypic subgroups. And as you can see, these subgroups carry different prognostic features, but also most probably predictive features that we are in the middle of trying to identify to find the best treatment for the individual person or personalized approach. What is, I think, important and what we are facing every day in the clinic, especially for the treatment of early breast cancer, is who can be spared therapy. The idea is we would like to treat the person who will benefit from treatment, but spare the side effects of the treatment from a person who really will not need it. So therefore, we are still in search and need for prognostic markers. And also, once we decide that a person will benefit from treatment, the question is which therapy will work the best. Again, therefore, we need predictive markers to make the best selection. We all in the clinical practice are using, and these factors have been validated with prognosis of breast cancer, but also with the decision making that goes hand in hand. So age, TNM, ER, PR, HER2 status, grade, and comorbidities are very important and validated prognostic features. Some of them are also predictive. And also for decision making, in addition to these factors, we also add patient preference, of course, because we might recommend treatment, but the patient might reject it. So I think that's always a very important factor in the equation. And actually, these factors I mentioned are available in the simple approach, Adjuvant Online. I think that we are all using in the clinical setting, at least. We are browsing through it, and that helps us with giving a patient quantification. Now, I don't think you can see all of the details, but I will walk you through it very quickly, because the point is here, if we add certain patient characteristics, age 50, ER positive, grade 1 here, grade 3 here, and the tumor is between 1 and 2 centimeters. Basically, we will get a range of benefit from chemo anywhere between 2.9 to 12.7%, depending on what grade we put in. And if you put in grade 2, it's 7.8%. So you can see already that even if all of the other factors are the same, including the comorbidities, age, and ER, grade really makes a big difference. So then the question is, how much can we really trust grade? Again, as I've shown you, the range is from 2.8 to 12 point something %. And unfortunately, we all know, and several studies have shown, that grade has a poor reproducibility, as we've seen, for example, in the NSABP-B14. And when we look at the literature, the overall concordance for grade is actually 43% only, and the lowest being for grade 2. Now, I just showed you in the previous slide how important it is to define whether the tumor is grade 1, 2, or 3, again, because the range can be from 2.8% to 12%, as I had given in the previous example. Now, another assessment many of us are using is also Ki-67 in the decision making, but even with that, if you recall a recent publication published by the International BGICSTV in Breast Cancer Working Group. And again, you might not read the details, but at this point, what they conclude is they say at present, the enormous variation in analytical practice markedly limits the value of BGICSTV. So most probably, though we are still using it, it's not very definitive and might not really help us tremendously in making decisions. So obviously, we need other tools that can help us making the best decision, treatment decision for the patient. And as you know, recently several tools have been developed that deal with gene-protein prognostic signatures. Examples include MammaPrint, PAM50, Oncotype, Mammostrat, and because of the interest of time, I will try to summarize for you the data we have and the ongoing trials for MammaPrint, Oncotype, and Mammostrat. Let's start with MammaPrint. MammaPrint is an FDA-approved for prognostication of patients with stage 1 and 2 node-negative breast cancer where the tumor is less than 5 centimeters. It does require fresh frozen samples, and the tumor cell content should be more than 30%. However, we have all seen recently published literature that they are now improving and are also trying to use this in a immunohistochemistry or paraffin-embedded tissue platform, and the success rate of this has been published in recent few trials. What this MammaPrint includes, it basically includes 70 genes that were identified by supervised analysis looking at 25,000 genes. And it was shown that this gene expression profile can predict either poor or good prognosis in a patient based on a 5-year recurrence risk. It is also an independent prognostic marker that identifies good prognosis patients independently from other known clinical factors, the ones we just went over with. Also, it predicts benefit from chemotherapy based on a recent study and then subsequently a few small studies. Again, please remember that these are all retrospective validation in small cohorts, and I will mention to you the prospective studies in a minute. And also, in continuation with showing benefit from chemotherapy, one study also looked at its usage in the neoadjuvant setting and identified that individuals or patients who fell into the poor prognosis group actually had a higher PCR. In other words, patients with a good prognostic profile did not respond well to neoadjuvant chemotherapy. A landmark study was actually published by Van Veer in 2002, where they modeled that these 70 gene 70 gene expression array can really differentiate patients into good and poor prognosis. In this cohort of patients, in all patients, you see the differentiation for disease-free and overall survival. She also showed that for the lymph node negative group in terms of disease-free and overall survival, and also in the lymph node positive group. So it does really divide into prognosis in all lymph node positive and negative patients. Now I want to switch briefly to Oncotype recurrence score model. As you know, it's a RT-PCR-based assay of 21 prospectively selected genes from paraffin-embedded tumor tissue, and 16 of these genes are cancer-related genes. I will show you in a minute which ones they are, and there are 5 reference genes. And what this assay does, it calculates the risk of recurrence score. And it was initially developed in the node-negative untreated group, but then also retrospectively validated in the NSABP-B14 study, again a node-negative, hormone receptor positive, tamoxifen-treated group. And in this study, in a multivariable model, the recurrence score had value predicting distant recurrence. So these are the 16 genes. They are related to proliferation, such as Ki67, invasion, HER2-regulated genes, and also estrogen-regulated genes. And the study categorizes, this score is categorized into low risk, intermediate risk, and high risk. And here you can see that in these low, intermediate, and high risk, the risk of distant recurrence over 10 years. So basically in the B14, the 10-year distant recurrence risk was determined and validated. In another retrospective validation study in the NSABP20, the recurrence score was also shown to correlate with benefit from chemotherapy in the high-risk group, but not in the low-risk group. And this is all in the lymph node negative. Oncotype was also looked retrospectively validated in another cohort of patients with lymph node positive disease, such as the SWOG 8814 study that Kathy Albane had presented and published in 2010. In this study, you will remember in lymph node positive, ER positive, postmenopausal breast cancer patients, patients were randomized to tamoxifen or two other arms of tamoxifen plus chemotherapy, either given concomitantly or sequentially. And in this study, when we look at the whole cohort, there was a almost significant trend towards improved disease-free survival when chemotherapy plus tamoxifen was used. So Dr. Albane validated this Oncotype score in this cohort and tried to see whether, if stratified by low, intermediate, or high risk, we could detect benefit in one of the subgroups for adding chemotherapy. And as you can see, in the low-risk group and in the intermediate risk group, the addition of chemotherapy was not helpful in this lymph node positive cohort. However, in the high-risk group, when chemotherapy was added to tamoxifen in these postmenopausal hormone positive, lymph node positive women, there was a benefit. So it appears that if in lymph node positive, you could consider a benefit from chemotherapy. However, again, remember, this is validation, but in a retrospective cohort and not prospective yet. So in conclusion for the Oncotype, what we can say is, in terms of level of evidence, it's validated in the tamoxifen-treated patients. There's experience in other populations I have mentioned, again, in retrospective cohorts, and it's included in different treatment guidelines, actually, including the NCCN and others. Its clinical utility, in terms of clinical utility, I think it really represents an area of a common disease type where we may be commonly over-treating patients, so it definitely is important to dissect out the individuals that should not be over-treated. And there's a potential for the results to influence treatment decisions. And for practical purposes, it's commercially available, and there's really no special processing required because you can do it on perf and embedded tissue and send it out for analyses. The third tool, or the third gene expression technique I want to mention is the mammostrat. It's also a risk predictor amongst ER-positive tamoxifen-treated patients. Its technology is based on immunohistochemistry, so you do not need fresh frozen tissue, and it's based on these 5 markers, including P53, that is shown here. And based on the scoring, it scores individuals or patients into low, moderate, or high risk. Again, retrospectively, this technique, the mammostrat, has been looked in the B14 in the tamoxifen arm, ER-positive, lymph node negative tamoxifen-treated patients, and in the tamoxifen arm of the B20, again node negative. And more recently, in about 800 patients, again ER-positive, tamoxifen-treated, but also 20% had lymph node positive disease, and everybody received hormonal therapy in that study. So when we look at these studies a little bit closer, in the B14, in the tamoxifen-treated arm, you can see that this mammostrat was able to show association between stratification by low, moderate, or high risk. But what we also see is that the low and moderate risk actually does very similar. So they're very similar. However, we see that the higher risk patients really don't do as well in terms of risk of recurrence. So this technique is able to really dissect out the really bad prognostic individuals. In the B20, which was looking at the addition of chemotherapy, you can see here, this is the table from the publication, that in all patients, tamoxifen plus chemotherapy was better than tamoxifen only, but the idea was to see if mamostrat could stratify in terms of risk. And what we see is that even in the low-risk patients, there was benefit from chemo, and in the high-risk patients, there was benefit from chemo, but in the moderate risk, there was no benefit from chemo. So what this really means is that when they did the test for interaction between chemotherapy benefit and the risk of group stratification, there was no statistically significant difference. So that means that stratification with mamostrat really does not help us identifying which subgroup should be selected for chemotherapy. So, and I tried to point it out several times that all of the studies so far are validation studies, but they are done on retrospective cohorts where we know the outcome. There are prospective studies, luckily, that I think will really help us feeling good about using these tests in our patients. One study is in the Taylor-X study was done in lymph node negative patients, which completed accrual, but we don't have the results yet. In lymph node negative ER-positive breast cancer patients, they applied to Oncotype score assay, and patients who had a recurrence score between 11 and 25 were randomized either to hormonal therapy alone or hormonal therapy plus chemotherapy. So the results of the study is heavily awaited. A recurrence score of less than 10, patients received only hormonal, and a recurrence score of greater than 25, patients received also chemotherapy in addition to hormonal therapy. A second trial using the Oncotype assay is currently going on. It's the responder trial that is undertaken in lymph node positive breast cancer patients. And basically, it has two different randomizations depending on whether the patients were tested before they signed consent or after. If they signed consent before they had Oncotype testing and had a recurrence score of less than 25%, then they were randomized either to chemo and endocrine or only endocrine therapy. If they had a recurrence score of greater than 25, these patients were not eligible and then received most probably standard chemo. The other registration is if patients signed consent after they had Oncotype testing somewhere else or came with results, and again, if they had a recurrence score of less than 25, they were randomized after signing consent to chemo plus hormonal or hormonal alone. And again, the study is currently accruing and hopefully will have results soon. And finally, the third study that is prospectively going on is using MammaPrint in lymph node positive or negative patients. 6,000 women will be accrued, and they are using the MammaPrint score as well as the adjuvant online. Good prognosis, patients will not receive chemo. Very poor prognosis, everybody will get chemo. However, the main study is when there are discordant cases, for example, good prognosis by MammaPrint and poor prognosis by adjuvant online, or vice versa. And then patients are being randomized to chemo based on either adjuvant bad prognosis or MammaPrint bad prognosis. So again, this study will also give us an idea about the gray zone patients. So I think what I want to say is that at this point, still, I think tumor burden and lymph node status is a very important predictor for prognosis or prognostic. We don't know if these signatures will help. Hopefully they will help and make our lives a little bit easier. A working group has gotten together and published this, looking at the analytical and clinical validity and the clinical utility of these tests. As you know, analytic validity is if a test's ability to accurately and reliably measure genotype of interest. Clinical validity is a test's ability to accurately and reliably identify or predict a relevant breast cancer survival endpoint. And clinical utility is if you use these tests and make a change that will show an important health outcome. So when they looked at the analytical validity, it looks like that they had convincing data for Oncotype and MammaPrint. When they looked at the clinical validity, again, Oncotype and MammaPrint was pretty convincing. However, the clinical utility, so whether it changes outcome in the patients, and most probably because we don't have data, the data was actually maybe adequate but not convincing. However, the guidelines, as I mentioned, right now tell us to consider genomic testing in ER-positive, HER2-negative, node-negative patients when we think it will help us with the decision whether to add chemotherapy. And of course, it's also patient's preference. And the second generation signatures right now, what I think the research community and we are all working on is further defining prognostic signatures in hormonal receptor positive patients, looking at genes related to immune response and inflammation, and analysis of genes actually expressed not in the tumor but stromal tissue. And in terms of predictive signatures, again, dissecting out the endocrine and chemosensitivity, but also which specific chemotherapy might be better for which patient, especially in the basal types, for example, and also predictive factors for targeted therapies. So I would like to conclude by saying that prognostic and predictive signatures can help in treatment decision for specific groups of patients and may be able to identify a group of patients with endocrine responsive disease that perhaps will not require chemotherapy, and we can save them from associated toxicities. Prospective validations trials are going on in lymph node negative, one has been completed, and also in lymph node positive disease. And also prospective validation studies are going on in multiple neoadjuvant treatments, neoadjuvant studies. And until results of prospective studies are available, I think the current guidelines still endorse the use of adjuvant chemotherapy in lymph node positive disease unless there are comorbidities and we don't feel comfortable using chemotherapy or it's patient's preference. Thank you very much for your attention.
Thanks, Dr. Ben, for your elegant presentation. Now the floor is open for questions. Everything is clear. Thanks again, Dr. Ben.
Thank you.
At the end of the session, I'd like to thank our speakers, chairperson, and audience. Now we will shift to the most important session in this conference, panel, multidisciplinary panel discussion. We will prepare the room for this. Thanks a lot.